All right, well, what I'm going to do is I'm going to run you through the diagnostic approach, this tree that I was telling you about this morning, how to start to sort out what somebody has. And it's a decision tree that looks like this. That looks very complicated, but I think going through it almost step by step is very illustrative about how we think these diseases are related and how they're unique. So I want to go through that with you. And a lot of this is really designed for a physician making the initial call, but I want you to work through it and make sure your physicians have done this and have thought about these various cousins of transverse myelitis and different forms of transverse myelitis. Okay, so what happens? How do you start off? Well, what we're talking about is defining the presence of a myelopathy. A myelopathy, you all know by now, is an acute spinal cord dysfunction. So the spinal cord is just not working. And so what the first thing is to define by a history and a physical examination, where is the spinal cord not working? What are some of the features about this? How is the bladder and bowel function preserved? And et cetera. So that's the first step that should have been done. And for an acute treating physician, you want to make sure that this is, for example, spinal cord dysfunction, not dysfunction of peripheral nerves. That would be a related disorder. Does anybody know what I'm talking about? There's an acute problem with peripheral nerves called Guillain-Barre syndrome. You've heard about that. A lot of you people have been told initially that you did have Guillain-Barre. So what is it then that defines a myelopathy? Well, there's really four symptom groups: motor, sensory, autonomic, and pain. So let's go through those four quickly. The motor can be anywhere from just a touch of weakness, maybe just a touch of clumsiness, all the way to complete paraplegia, which means no movement of the legs, or in some cases quadriplegia, which is no movement of the arms and legs. Usually, in the spinal cord, the legs are involved more so than the arms, and the arms may be only just a touch involved, while the legs may be completely not moving at all. Although there's an exception to that. So some of the lesions that we've talked about, and you've seen some MRIs today, are right in the middle part of the spinal cord. And if you remember your neuroanatomy lessons from Dr. Greenberg and Pardo this morning, parts of the fibers from the arms come in more in the middle of the spinal cord, whereas those from the legs are right out at the very surface of the spinal cord. So if there is a lesion smack in the middle of the spinal cord, the arms may be more likely to be involved than the legs. Tone. So the physician taking care of you should really start to play with the legs, play with the arms, ask you to go real dead and loose and floppy and see how the tone is. The tone is basically the resting innervation to the muscles, the resting firing of these nerves. And when we are relaxed, those muscles should be relaxed. But all of you who've had a myelopathy, transverse myelitis, Devic's disease will know that those legs are stiff. They fire all the time. Sometimes they have these spontaneous spasms. Those are all manifestations of the motor involvement of the spinal cord consistent with a myelopathy. Sensory, paresthesias is really a pins and needles sensation. It could be numbness. Now, in many cases, numbness, people will describe this differently, is really the absence of sensation. So if you try to touch a patient and they feel nothing, they will often say, well, it's numb, I can't feel a single thing. Pins and needles is a little bit different, right? Because that's a weird sensation. To be honest with you, I actually like that better. Some of you come in and say, boy, I've got all kinds of pins and needles, and it's really uncomfortable, and I say, good, right? Because that means that those sensory nerves are firing. They're not firing normally, but at least they're awake and firing, okay? Sometimes people will describe it as a warmth or a burning sensation, and the physician should really be doing a pinprick down the front and the back to define what level of the spinal cord is involved. because the sensory nerves go into the spinal cord at a specific level. And so to define a myelopathy, you really need to define a sensory level, if at all possible. And you'll hear us say stuff like, oh, this is a T6 lesion, or a T4 lesion, or a C5 lesion. It's all really dependent upon that sensory examination that's done. So what about autonomic? That's the second of the four cardinal groups. Urinary urgency is most common, and in fact the most sensitive sign for an involvement of the spinal cord, and that really is defined as a decreased interval from bladder fullness to evacuation. Put simply, somebody says, uh-oh, my bladder's full, I got to go now or I'm going to have an accident. And that can happen during the day, it can happen during the night, and some of my patients will say, oh, it's about 30 seconds. That means I've got 30 seconds from the sense of bladder fullness to when I've got to get there. And sometimes the medicines we use try to get them 5 minutes or 7 minutes or 8 minutes of time from sense of bladder fullness until they've got to go. More ominous or more worrisome is a urinary retention, where people sometimes say they can feel bladder fullness, but they can't go, and they need to be catheterized. Bowel urgency and retention typically go together, although most people report more notably in the acute phase, urinary urgency or urinary retention. Pain is a big feature of transverse myelitis, or indeed of any myelopathy. And for those of you who have it, you know it can be the most debilitating aspect of this, the worst aspect of this. It can be burning, or the radicular means it's shooting to one side or down one arm or down one side. It can be a tight squeezing or a banding sensation, and it can be very difficult to treat. We'll talk about this later. There are lots of treatments. There's a pyramid approach where you start with the simple things and you move up until you get better control of this. So I'm not going to go over this table, but we've published this, and this is part of our approach to educating physicians who don't see as much of this as we do, that there are clinical features that suggest particular types of myelopathy, whether it is neuromyelitis optica, or it's associated with a vascular problem, or it's associated with a rheumatologic problem. There are clinical and radiologic things which can be very helpful in distinguishing between those possibilities. There are radiologic features as well. So most of you in the acute phase, if a myelopathy is being considered, will get an MRI. And again, this is more for the physician than to go over each of these here. But there are certain things about the MRI that can say, look, this is more like MS, or neuromyelitis optica, or sarcoid, or a stroke of the spinal cord. Those are variations on the theme. And what we know by now is this patient has a myelopathy, but we haven't yet figured out what type it is. Now, getting back to this Guillain-Barré. Guillain-Barré is the GBS up here. It is an acute autoimmune inflammatory attack of the peripheral nerves, not the spinal cord. It, too, like transverse myelitis, usually follows on the heels of an infection and is really an example of the immune system gone amok. So that the immune system has become activated in response to the infection, but then it gets it wrong and it attacks the spinal cord in transverse myelitis, the peripheral nerves in Guillain-Barré. Now, there are very simple things that can be used to distinguish between these two, but they often get mistaken. For example, I talked to you about a spinal cord sensory level. So that's where the physician has to figure out if there is an area on the trunk below which sensation is impaired. Because if that occurs, the patient says, I feel this normally, not at all. That's a sensory level. That's a myelopathy, period, not a Guillain-Barré. Very clear way to distinguish between those two. Second thing to distinguish between those two, the autonomic findings. I already told you this. Bowel and bladder are very commonly abnormal in myelitis, but almost never involved in Guillain-Barré. By contrast, in Guillain-Barré, the heart beats too quickly or too slowly. So another very clear-cut way to distinguish between these two. There are some physical exam findings that are able to distinguish between Guillain-Barré and transverse myelitis, and the spinal fluid also distinguishes between the two. In transverse myelitis, what you see are lots of white blood cells. That's the inflammation. In Guillain-Barré, you don't see white blood cells. All you see is an elevated protein. So those are the ways that you can usually distinguish between these two. Okay, so the first step now, we've defined this as an acute myelopathy. The first step is it compressive? In other words, is something pushing the spinal cord from the outside? Or is this an intrinsic within the spinal cord inflammatory or vascular process? So how do you do that? How do you figure that out? Well, ideally, we'll get this MRI that we've been talking about because it'll help us get towards transverse myelitis, but it also defines if it's compressive. Here is an example of an MRI, and you've seen several today, but this is really a compressive myelopathy. It's called spondylosis. Spondylosis is a word which just means arthritis. As we age, the bones kind of squeeze in a little bit about the spinal cord. The spinal cord is the gray column here. And you see the white on either side of it. What is that white on either side of the gray spinal cord? Spinal fluid, not inflammation, spinal fluid. And the spinal fluid is around the spinal cord, bathing it and nourishing it. But look what happens here. There's none of that, right? And that's your sign that the bones have crunched in a little bit. And so you can imagine that this person might be doing pretty well, but gets a little bit of a motor vehicle accident, has a little bit of a hyperextension, and all of a sudden gets a myelopathy. That's not transverse myelitis, right? That's a compressive myelopathy. The bones have actually squeezed the spinal cord. That's cervical spondylitic myelopathy. This is the most common cause of myelopathy in the elderly. May have a minimum antecedent injury, falling down the stairs, or even a car accident that kind of brought this on. The arthritis had been there, but was okay until this accident occurred. Mostly a hyperextension type injury brought this on, and from a clinical management, immobilize the neck, and we can get flexion or extension x-rays and an MRI to define how bad this is and what the treatments would be. Very important to get this out of the way right up front. There are other ways, right, that can help you distinguish whether it's compressive or not, and we're going to get to that because we want to know if there's any inflammation, right? Because in a compressive myelopathy, there won't be any true inflammation. It's not inflammatory at all. It's compressive. So how are you going to define if this is an itis, as in transverse myelitis, itis being inflammation? Well, you're going to get a lumbar puncture, and we're going to go back and reevaluate now this MRI. The MRI was given with gadolinium. Gadolinium is the stuff given into the vein. That stuff should stay in the vein. If it doesn't stay in the vein, but gets into the spinal cord, it says that the barrier between the blood and the spinal cord has been broken down. This dye gets out and lights up like a light bulb. That's inflammatory. So you got two ways to define whether it's an itis. The dye gets from the vein into the spinal cord, and the spinal fluid is hot. When I say hot, I mean lots of white blood cells. Okay? So here is a case of a 61-year-old man with a history of a subarachnoid hemorrhage 30 years ago who developed an ascending left leg numbness over a year, and then bilateral lower extremity weakness, and ultimately progressed into a wheelchair. Does that sound like transverse myelitis? No, a couple things worry you that it's not actually an itis, but maybe some other cause of a myelopathy. One might have been that there was a subarachnoid hemorrhage, which is a bleed, before, and the other might be that it progressed over a year. So what do you think it is? What's that? It could be compressive. That's the first thing that you should think about. Or it could be vascular. Those are the two things at this point that you would worry about. Now, CSF was normal. So there you have it. It's not inflammatory. It's going to be compressive or vascular. Also, the MRI shows a non-enhancing lesion. So there's a lesion, a plaque, something, but it's non-inflammatory. Here, I don't know how well you can see this, but you can see a little area of bright signal in the spinal cord and then a dark area above and below it. So this actually happens to be just an abnormal collection of a blood vessel called a cavernous angioma. So it's just an abnormal blood vessel. It's not inflammatory and it's not compressive, but this is really critical to make this diagnosis because it's not that uncommon, and of course the treatment will be different. What was done for this? This vascular abnormality was removed. Once it was removed, the pressure within the spinal cord got better and the patient improved. There's another type of a vascular malformation that you need to know about. This is called an AVM, arteriovascular malformation. It really occurs only in people over the age of 40, usually only in males, and it presents with pain, progressive weakness, numbness in the buttocks and perineal area, claudication, which means pain on walking, and urinary urgency. It is a slowly progressive or stuttering course over years. The etiology of this is this increased venous pressure by virtue of this AVM, and I'm not going to get into this except to say that what happens is the arterial venous malformation causes the spinal cord to be too congested because the spinal cord cannot drain blood away. And people progress into a wheelchair, and they may be there for a year or 2 or 3. And the beautiful thing about this is if you ultimately do make the diagnosis and you treat this arteriovenous malformation, people may get better. They may have a return of function as you resolve this congestion within the spinal cord. This is what it looks like. This is an example of this arteriovenous fistula on the surface of the spinal cord, and this is what it looks like when we define it by a spinal angiogram. Okay, now I'm going to go through the rest of this because now we're going to say, look, there is inflammation here, unlike those that I've previously taught you. There is inflammation as defined by what? What are the two ways? Hot spinal fluid and gadolinium enhancement on the MRI. Now we've got to sort out what type of itis it is. So the first thing is to see if it's an infection. Is the inflammation there because it's a direct infection of the spinal cord? And this will be on the quiz at the end, but these are the things you think about, and there's a whole series of tests that we often will run in this context. There is one thing that we see fairly regularly, which is EpsteinBarr virus. EpsteinBarr is a herpes virus, and it is important to look for that in the acute phase of a transverse myelitis because you can define the presence of the virus in the spinal fluid and can initiate antiviral therapy if you catch this early. So you think about this because there are appropriate antibiotics or antiviral therapies in the case of certain infectious myelitis. Okay? The second step then to define the type of itis it is could this be part of a systemic rheumatologic disorder? Is this really part of Sjogren's or lupus or sarcoidosis? And Julius Birnbaum is going to tell you about that in a bit in some more detail. But again, there are a series of things that need to be asked because if they are present, a rash, swollen glands, fevers, chills, night sweats, blood in the urine, those types of things make you think that, yes, this is transverse myelitis, but it's really part of a systemic rheumatologic disorder. It's important for a couple reasons. One, you've got to treat the systemic rheumatologic disorder Two, the risk of recurrence is much higher than if it were transverse myelitis in and of itself, not associated with a systemic rheumatologic disorder. Sjogren's syndrome, you will hear from Dr. Birnbaum, so I'm going to skip this for now. But we have also found that transverse myelitis is associated with antibodies that you often see in patients with Sjogren's syndrome. And so there's an overlap here. And in this case, we check at first onset of transverse myelitis for particular antibodies, in this case called SSA, or anti-Rho antibody, because if it is present, it, like NMO-IgG in the appropriate context, predicts recurrence. And so here we are in the first phase of an acute attack, trying to define what the risk is of recurrence. And the SSA and the NMO-IgG antibody both help with that. Who's heard of sarcoidosis? It is a relapsing autoimmune disease that often involves the lung, but can affect the spinal cord. It can affect the brain and the optic nerves as well. Something important to consider. There are certain tests which we will ask for to rule this in or rule this out. It is important to know because it too can be recurring over time. Okay, so now what if it's inflammatory but it's not associated with a systemic rheumatologic disorder or an infection? The question is, where is it within the nervous system? Is it just one spot, or is it multiple spots up and down the brain and the spinal cord? So we're interested in defining if it is multifocal CNS inflammation. So you need an MRI of the brain, you need an MRI of the entire spinal cord, and you need some other tests such as evoked potentials or OCT to test that. Because this is what we're down to at the very bottom of that chart. You can have idiopathic transverse myelitis, you can have longitudinally extensive transverse myelitis, and Sean already told you that that fits most appropriately in the context of the neuromyelitis optica spectrum. And so that's why we put this over here, because it's really important to know that that's more likely to involve the optic nerve ultimately. It's also more likely to recur, and we think of those treatments such as Rituxan that are effective for neuromyelitis optica, and the NMO-IgG helps here. What if it's an acute partial transverse myelitis, meaning it wasn't that severe, it was fairly mild, asymmetric, people were not catheter dependent, it was mainly sensory symptoms? That's good, right? Dr. Greenberg told you this. But that actually is more likely to go on to become something like multiple sclerosis. And so that raises our warning flags that this is the beginning of what is ultimately to be defined as multiple sclerosis. And the reason we have to get to all of these, and the reason why these criteria are important, is because we think the therapies differ. The risk of recurrence differs, and the most appropriate therapies differ. And that's why going through this exercise, I think, is important for the physicians, because it stratifies into different categories. Okay, I've already told you this. There are certain MRI and clinical factors which tell us, uh-oh, this is really ultimately going to be multiple sclerosis. The image looks different, the presentation looks different, the spinal fluid looks different. So now let me just spend a few seconds with you telling you about idiopathic transverse myelitis. I've already gone through the various shades of this, the various cousins of transverse myelitis. But idiopathic transverse myelitis in and of itself is typically monophasic and monofocal. Less than 10% of people in this group will recur. We still don't know, although I told you this morning about auto superantigens and post-infectious autoimmunity. So I've told you that in many cases, it is the infection which triggers the immune system to lose tolerance for self. And we know that to be the case in many cases of transverse myelitis, in large part because of some of the work that I told you about this morning that Philippe Llorens had published. What we don't know is why a specific region of the spinal cord. But this is what it looks like. This is the itis, right? So this is the spinal cord, which was from a biopsy, and what you're seeing is a massive infiltrative inflammatory process. Each of the blue dots here is an immune cell. Well, those immune cells should be in the blood surveying for infections. What the heck are they doing all amassing within the spinal cord? And the reason is they've been called there, and they have been recruited in large numbers and are actually injuring the spinal cord. Here's a view around a blood vessel, and you see, even within this small area, several thousand immune cells that are recruited into the spinal cord. And so this is our task in the acute phases, is to recognize that the immune system has gone amok and to call it off as quickly as you can. Because the results of that inflammation can be either demyelination. Here seen in one example, the blue color here is for myelin, and what you're seeing are multiple areas of demyelination. But the alternative is a more severe type of transverse myelitis, which the result of that inflammation is necrosis or axonal injury. And that tends to occur in the people who had a more severe presentation and are left largely or complete with an injury. No bowel, no bladder, no sensory, no motor. So why did, in some cases, the inflammation result in demyelination, which is milder and may get better, but in other cases will leave you with a complete necrotizing injury? Well, we've started to look at that, and we've got some answers to that. So we started the transverse myelitis in 1999. We've now seen around 1,432 patients with an acute non-compressive myelopathy, and we've sorted them out into these various categories. Now, we did this at one point, and we haven't kept up with, but we've sorted them into all of these different bushel baskets, right? What kind? Was it compressive? Was it non-compressive, but also non-inflammatory? And if it was inflammatory, what type? Infectious, associated with a rheumatologic disorder, or et cetera. And so this has allowed us to really understand each of these subgroups of transverse myelitis, and we focused on, for the sake of this understanding the pathogenesis, the idiopathic group. Why do people get idiopathic transverse myelitis? And Adam Kaplan said about doing this, looking at the cytokines or inflammatory factors. I told you it's inflammatory, but we didn't know much more than that it was inflammatory. So what if you said, look, I want to see what type of inflammatory factors are there? Well, it turns out that there's only a few inflammatory factors that are elevated. One of them is interleukin-6. You can see here by this these two very bright white dots that are present in the transverse myelitis patient, but not in the control. So we did that one time, and we said, cool, but maybe unique to that one patient. We did it 10, 15, 20, 30 times, and said, look, this is something which we see an awful lot in transverse myelitis patients. And so we graphed that, and what you find if you do this now over 20 patients is that they all look the same. They've got really high interleukin-6, and they've got not much else of anything going on. So really quite interesting as a biomarker for transverse myelitis, but also maybe it too, like Sean was talking about with the NMOIgG. Maybe it too is involved in the pathogenesis. So that's the way we think about it. Is it a biomarker only, or is it involved in the disease itself? I won't go about what we know of interleukin-6, but we know that it can injure tissues. We know that it can injure the heart, for example. And when we looked at the CSF IL6 levels of a bunch of patients, we found that it was a little bit elevated in multiple sclerosis, but man, was it elevated in transverse myelitis. Normal people have 2 picograms per mil. Transverse myelitis patients, on average, have about 435 picograms per mil of interleukin-6. So that was very informative from a diagnostic perspective, and what Adam showed in his work is that the higher the IL6 is in the acute phase, the worse you do long-term. So this is just a graph of that. This just shows you the EDSS, which is disability. Those who are at 10 are very bad, and there's a direct correlation between these two. So again, the higher your IL6 levels in the acute phase, the worse you do long-term. So much so that you can divide patients in the acute phase of TM into 2 groups. They come in with low IL6. Virtually all of them walk independently again. They come in the high IL6 group. They never walk independently again. Everybody hear that? That's my daughter. Put that on my ring for Raiders of the Lost Ark and Indiana Jones. So that, I think, is very important as a diagnostic tool, and we are now using this on a regular basis. Yeah, sure. How long does the IL6 level last? Just in the acute phase. Within the first 2 weeks. Yeah, so if we look, we certainly know that by 6 weeks the interleukin-6 levels have gone back to normal. And in fact, interestingly, although we've only done this in several patients, not more than that, in those in whom the IL6 has not gone back to normal, those are the people who will recur. So at 6 weeks, most people, their IL6 level has gone back down to 2 picograms per mil. If it hasn't, it bodes poorly for a chance of another recurrence. But it's only helpful in the acute phase. Okay. So, yeah, question. If there is a recurrence, does the interleukin-6 level change? The answer is yes, it goes back up. No, it would be into one of those different boxes. The question is, would it change the diagnosis? No, it goes into one of those different boxes, but it does tell you that chronic immunosuppressive therapy is going to be required. That indeed this process has not corrected itself, because in the majority of TM patients, the autoimmune dysregulation, the immune system has gone amok, but it quickly corrects itself. But in some patients, that doesn't occur. So this is where we are now. I haven't gone through the data, the animal data showing you that interleukin-6 is actually very clearly involved in the pathogenesis here. But that is the case, and it now raises, once you've got these participants in mind, now it gives you targets. Now it says we can think about rational approaches to drug therapy to block this pathway and see if patients will do better. Because remember, I told you this morning, the tools we've got currently are pretty blunt and pretty crude, and were predicated on the fact that we had no clue what this inflammation was about. But if we did, and we now do, you can think about more specific therapies, and each of these green boxes is really one of the things that we're hoping to look at and to test. So I will stop there and show you a few pictures. This is Paula, obviously, with my daughter and Adam Kaplan's daughter, and this is at the Victory Junction Gang Camp. And one more, this is Sandy with his hair colored pink and purple. His nails are done. But so are mine. I'll stop there.
Might be a good biomarker, but you only find it in the CSF, which...
Only in the spinal fluid is IL-6, not in the serum, unfortunately. We had hoped that it might be a serum marker. Wouldn't that be cool? Not the case. So for a serum marker, you're going to need Ben's stuff that he was talking about, and he's developing. Spinal fluid from a lumbar puncture. Interleukin-6 is found in the spinal fluid, yep, not in the blood. It's made by the central nervous system cells as part of the initial inflammatory response. We think it then recruits all these immune cells in, so it's only in spinal fluid. Sir? Would the IL6 be a standard part of a result of a lumbar puncture? Absolutely not. Not tested. Not tested. And it's hard because the spinal fluid has to be obtained, decellularized. In other words, you get rid of the cell debris, take the supernatant, freeze it, and then send it to somebody, including us. But a lot of clinical labs will do it. But if you just take the spinal fluid, it's got a lot of cells in there and things like that, the results are weird. So you have to get rid of the cells first and then quickly freeze the spinal fluid. Ma'am? What percentage of the neurologists throughout the country know to look for interleukin-6? Very few. Very few. And so how do we get that out to them? We're trying. We're trying. And it's being used more. In fact, we're starting to see people who come into the Transverse Myelitis Center now, and they've had their IL6 level tested. It's getting there, but it's slower than we would like. Lou?
Sean mentioned that when he used the term Aquaporin Channelopathy would lead to more specific treatment. But when he talked about treatments for NMO, he just talked about the standard, precedent how patients get based on. How would you go about, especially considering it's such how would you go about having a disease-specific treatment for Aquaporin for an NMO spectrum disease, especially if pharmaceuticals are
So the question is how... Yeah, the question is how would the identification of NMO, for example, as an Aquaporin Channelopathy, how would that allow you to design a very specific therapy to that? It's hard. There's no immediate answer to that. But I think what it points to, from my mind, is that if you can understand how the Aquaporin 4 channel function is altered, there are things that modulate water channel function. And there are drugs that enhance water transit and those types of things. So it is possible that the therapy would directed more at reestablishing normal water channel conduction. But we don't know yet. What we're interested in actually is very much in how did that start in the first place? How did you develop an autoimmune response to the water channel? Because we think something happened to make the immune system think it was foreign. Would you always have an elevated white blood cell count in your spinal fluid if you had transverse myelitis? No. It usually goes away completely, again, by 6 weeks. So normal white blood cells in the spinal fluid, 0 to 5, it should return to normal. If it doesn't, again, it worries us that you may be at a risk for recurrent disease among one of the other boxes that I told you about.
But if you were tested at, say, 3.5 weeks or 4 weeks, it should be elevated.
It would be elevated in the acute phase of transverse myelitis, meaning the white blood cells, out to around 6 weeks. Yep.
Do most of those results hold true in pediatric cases?
Do most of those results hold true in pediatric cases? Less so. The two things that are less reliable in pediatric cases is gadolinium enhancement is less common, especially in infantile cases, and a robust cellular inflammatory response. And it's very interesting because those are the two things that I told you define an itis, and yet in kids, especially in infants, they're not as reliable. So in kids, what we have found on many occasions is by all the other criteria, this is non-inflammatory. There's no gadolinium enhancement, and there's no cells, and yet the IL6 level is sky high. So that's quite interesting that may be the most reliable marker of inflammation, more so than the classic ones that we use to diagnose. Greg? question is in the infantile cases, which often are the worst. The worst outcomes in some cases come from kids who had transverse myelitis before the age of 1 year and old. Is their IL6 level higher? And in many cases, it is. The highest we've actually seen is in NMO patients, but we've seen 4,000 and 5,000 picograms per mil in infantile TM cases who were left quadriplegic and ventilator dependent, unfortunately. Ma'am?
So you're in the last movement thing. Do you go back and do another spinal tap, assess if there are greater risk for recurrence, or what if they never even had one?
We haven't felt justified in doing that at this point. We may get to that point. So we have to prospectively assess. Oh, I'm sorry. The question is, would you go back and get a follow-up spinal fluid to assess a return to normal IL6 levels? And it makes sense. And we often will do that, but we don't feel like we're fully justified at this point in using that to guide treatment decisions. It's a bit too early. We hope to get there. Now, yeah, so that's a good question. And the question is, that's exactly the point. And now that we know that IL6 is not only a biomarker, but is participatory in the disease, it's causing the injury. Are there better ways to downregulate this IL6 quite quickly? And we think there are. And we think that that will be a useful way to call off the disease progression, because we give steroids now, and many of you have received steroids and recognize that it's not that good. It helped to some degree, but could we do better? And so there are certain things. For example, one of them that we're very interested in testing is thalidomide. Thalidomide is a very good drug in certain circumstances and is very good at decreasing IL6 and the responsiveness to IL6. Sounds perfect, right? So we'd love to do this, but that's a tough study to get done, right? Because you need patients to get into a hospital, to get IL6 level tested quickly, and then to get put on thalidomide or placebo in addition to steroids. I think it's a really good study. I think it would be very important to do, but even at Hopkins, we don't see enough in the first several days. You really need a patient within the first 4 days of onset to do that study. And so that, by definition, has to be a multi-center study. Wow. Wow. All right, that's good. Yeah, so there are two cytokines, IL6 and TGF-beta, that push the immune system into a particularly nasty cell called a IL17 cell. So you heard about Th1 cells. Well, there's one that is a really bad cell that is just a T cell out of control. And that's a TIL17 cell. And IL6 is one of the things that makes your body make TIL17 cells. And so, yes, we've been very interested in that. And in fact, we've looked in our transverse myelitis patients, and they have much higher levels of TIL17 cells than controls. Well, duh. But they've also got much higher level of TIL17 cells than MS patients, than sarcoid patients, and then NMO patients. So there's something very unique about transverse myelitis and elevation of IL6 that drives the production of these cells. You could have yanked me off before, I'd just keep going.